Good afternoon and welcome to the March 8th Disaster Information Specialist webinar. We are very excited that you are at our webinar, and we know that some of you are experiencing some weather, let's just say, and we wanted to let you know that we have resources for weather. Let me see. I always forget that I have to open everything up in Chrome. So let me go ahead and open this up in Chrome. And I would recommend that you go to our Disaster Lit database and enter in winter and cold. I had a better, that's not the right one. Maybe Robin, you can find the link for me for the search for winter weather. I forget that my screen won't share on Firefox. So while Robin is looking for that, and I'm sorry, I apologize about that, I did want to say that the National Library of Medicine has released the National Library of Medicine Strategic Plan, which is called A Platform for Biomedical Discovery and Data-Powered Health. And so Jen is going to put in the chat box the link to the blog post that the National Library of Medicine Director Patty Brennan posted about the strategic plan, with the focus of this strategic plan on data science. And also in her blog post, she includes information that the National Institutes of Health has issued a draft of their strategic plan, which is also a data science plan. And along with that plan, they also have a request for information seeking input from all stakeholders. So that input is due April 2nd, and we would highly recommend you taking a look at both plans. They have to, of course, work together in collaboration with each other. And if you have input, please take a look at that. Here's the link to winter or extreme cold. For those of you who are out there working in the cold, shoveling, helping rescue people, you can take a look at our Disaster Lit websites and our database, and you can find some of these resources on how to protect people in emergency preparedness and severe weather, things like that. And finally, it is International Women's Day, and so we do have, let me try this again. We do have a page on our website for, I want to get the exact right, pregnant women in disasters and emergencies. So in honor of International Women's Day, take a look at this webpage and have some fun. I'm going to stop sharing my screen, and I'm going to move the presenter ball to Melissa and have her take over. Melissa is she's a nurse with a master's in public health. She's the director of the Division of National Healthcare Preparedness Programs at the HHS Office of the Assistant Secretary for Preparedness and Response. And I know I'm very excited to hear Melissa's presentation, and please use the chat box to put any questions that you have for Melissa in the chat box, and we will keep track of the questions, and at the end of the presentation, we'll make sure that Melissa has access to all of your questions. So I'm going to mute myself and turn it over to Melissa.
Thank you so much. I really appreciate it. And thanks so much for taking the time today to have me present about the Hospital Preparedness Program and the CMS Emergency Preparedness Rule to you. I'm the director of the Division of National Healthcare Preparedness Programs at ASPR, which has a few programs under it. The most visible is the Hospital Preparedness Program, which we'll mainly be spending most of the time today talking about. So to give you just those who are not familiar with the Hospital Preparedness Program that I'll be calling HPP throughout the presentation, it is a cooperative agreement grant program that's administered by us here in ASPR and is the only source of federal funding for healthcare delivery system readiness. Many of you may have heard of the MMRS programs from years ago and other programs throughout the federal government that were also aimed at healthcare preparedness, but those have since gone away, and the only program left for what is largely a private healthcare delivery system in the U.S. here is the HPP program. We are really charged with preparing the healthcare system to save lives during emergencies that exceed the day-to-day capacity of the health and emergency response systems in the United States. We think it's really important to build our emergency healthcare response system off of a day-to-day system, because we all know that healthcare providers and healthcare facilities rely on each other every single day. And what we need to be able to do is basically take those relationships and somewhat put them on steroids during an emergency, not be spending the time creating new relationships or planning in new relationships that we don't cultivate every day, that we would expect to turn on during an emergency, because I think we all know that that wouldn't really work. So we do this by developing what we call regional healthcare coalitions. And these are groups of healthcare providers and facilities, as well as other organizations and governmental community partners that are really charged with bringing these really diverse facilities and organizations together. And we all know they're really competitive with each other, especially in metropolitan areas or suburban areas. You'll see commercials on television every day trying to essentially recruit patients for what are in many cases somewhat elective type of procedures, whether we see, cardiac stenting commercials, or whether we even see commercials aimed at new mothers and fathers who will be delivering babies, all trying to vie for their market share. But that's the last thing that we want to do during an emergency. We want to make sure that these competitive organizations that have very differing priorities and obviously are on a day-to-day basis hesitant to share kind of business-related information with each other, we want to break down those walls and make sure that we can do that quickly during an emergency and that they can actually work together, not as at competing interests. We promote a sustained national focus on improving patient outcomes, and we make sure that we try to decrease the need for supplemental state and federal resources during emergencies, whether that's in terms of funding or even just in terms of our own assistance, because we really do believe that all emergencies are local and that it's really important that the local delivery system be able to maintain both capacity and capability to the extent that they can. So for those who are familiar with HPP and what I'll say the early days, the program started in 2002, right after 9/11 and the anthrax attacks. And when I say the early days, I mean really about the first decade of the program or so. For about the first decade of the program, the funding went to awardees, and we are $255 million a year program going to 62 awardees. Those awardees are our state public health departments of the 50 states. They are 4 directly funded cities, Washington, D.C., New York City, Chicago, and L.A. County. And they are also our freely associated states and as well as territories. And the funding goes to those health departments, and then from those health departments, they are currently charged with funding those healthcare coalitions that I just spoke about. But in the earlier years of the program, the money went to those health departments, and then those health departments were charged with only funding hospitals. So many of them took their total award, and they would divide it up among the number of hospitals through some kind of a formula about number of ED visits a year or number of total beds or number of staff beds, and really gave it to those facilities for their own individual preparedness needs. A lot of those preparedness needs were equipment purchases. Many hospitals weren't planning for large surges of patients prior to 9/11 and just didn't have both the specialty kinds of equipment that we were thinking about, whether that was personal protective equipment for biological attacks, or they didn't have the volume of equipment they would need to account for a mass surge. So we saw a lot of purchasing of equipment and pharmaceutical caches for prophylaxis and for treatment and other kinds of emergency supplies and equipment. I'd like to say we got a little bit smarter, both through living through H1N1 and various other kinds of emergencies, where we saw that the key to a well-prepared healthcare system is actually those healthcare facilities working together, not just preparing them individually. In 2009 H1N1, we would often go to various different kinds of hospitals in a metropolitan area, and we walk into one of them, and that hospital would tell us, we don't know what we're going to do. We only have one bed and one ventilator left, and what happens if we get two patients? We're going to have to make a really terrible decision about, whether we take someone off a ventilator or if we just, deny the access to a ventilator to an incoming patient, or what it is that we do. And these are terrible decisions that we have to make because we're so scarce on resources. And then we would walk a couple blocks down, literally in one city, it was 13 blocks down the road, and go into their ICU, and they had, 22 beds available, and they had plenty of ventilators. They even had an ECMO that was not currently being used. And we said to ourselves, there's a problem here. Yes, these are competing healthcare systems. These two hospitals are owned by different business partners, but there is no reason that this one hospital should feel that they are so at capacity that they don't have any idea that there's tremendous amounts of capacity just down the road. We've got to get them to work together. And another example that was really apparent to us was I believe it was 2012 derecho. Now, the derecho was a kind of a storm that's really rapidly developing and came here to the mid-Atlantic area very quickly in the summer, knocked out power to almost all healthcare facilities. Hospitals were certainly on generator, but we learned two things that were very important then, and one was regarding dialysis patients. The dialysis facilities, since this was kind of a no-notice event, it wasn't like a hurricane where we knew it was coming, the dialysis facilities didn't have time to do any kind of pre-dialysis, nor did they have time to kind of notify their patients and tell them to go to a different facility. So a lot of them didn't have generators, and a lot of them just simply shut down. And a lot of the patients who not even that long ago, maybe 5 or 7 years ago, would have been inpatients in a hospital because they were truly that sick, are now living in the community and living at home every day because of advances in medical technology and simply changes in our healthcare delivery system. And these patients require power. They require electricity to be able to plug in the equipment that they rely on to stay alive. And without those two things, what we kept hearing from the hospitals in this mid-Atlantic area that got hit by this derecho was that the emergency departments were just completely swamped. They were full of patients that did not need to be there. Dialysis patients that live at home every day and go for dialysis 3 times a week, and patients who live at home every day and just needed a plug. That's all that they needed. But they had to be admitted to a hospital because there was no one else that could provide services for them. So those hospital beds were being taken up by these patients who obviously had a need, but certainly not an acute medical care need. And then they were swamped by people who were actually either survivors or victims of the storm themselves, whether it was downed trees that caused trauma accidents, or people who really had emergencies. Heart attacks still happen even during emergencies. Strokes still happen, and there were no beds for these individuals. So we said we really need to figure out a way to get the whole healthcare system working together. And as a reason, HPP is no longer just about hospitals anymore. We're about all of healthcare, all different types of healthcare facilities and partners all planning together. And we also switched at that time away from not just changing from a hospital to a coalition model, but away from what we call equipment purchases to more of a capabilities-based approach to planning. So the way I like to think about that is, regardless of whether you're talking about a natural disaster like a tornado or a hurricane or an infectious disease outbreak, there are some basic capabilities that need to be done across the entire healthcare system in order to be sure that we're ready. So again, regardless of what caused the emergency, the tornado or the infectious disease outbreak, we need to make sure that we're all communicating with each other. We need to make sure that we all are aware of what each other's resources are, because we're going to need resources during both of those two types of events, even though they're very different. We need to make sure that we can continue to provide healthcare delivery services, one which would be a structural reason why we might not be able to, the tornado. The other being that we are limited in staffing the infectious disease outbreak because our staff might be getting ill. And then the last is obviously both of those and everything in between require a need to plan and respond to a medical surge. So what we like to think of our capabilities are inside of each of those is guidance for the individual facility, guidance for the coalition, and guidance for the jurisdiction on what their roles are in making sure that the U.S. healthcare delivery system is able to plan for and respond to an emergency in kind of what we call the ideal or the gold standard. We don't say that these capabilities are what HPP needs to do, because again, with $255 million as a program influencing a multi-trillion-dollar healthcare system, there's no way $255 million alone can pay for what's needed to do to build all of these capabilities. We believe that if you have your facilities, your coalitions, and your jurisdictions well planned for these capabilities, you're about 80% of the way there, and that doesn't matter what type of hazard it is. But at the same time, some hazards are just really unique. So if you take something like Ebola, you need all of the things that you'll see on the right-hand side of the screen. You need all four of those kind of capabilities, but we needed some really specific things as well. So we called out about the 20% pivot. We needed a specialized biocontainment units. We needed much more training on really specialized kinds of personal protective equipment. We needed very intensive type care for a virus that had never yet been seen in the United States. So there's definitely a need for every emergency to have its own flavor and planning factors put into it. But again, the core of all this still requires a lot of the same baseline capabilities no matter what the emergency is. So here I'll share with you, again, the four capabilities, and if you, as I'm speaking, just kind of quickly glance through the goals, no need to read them entirely. But again, the foundation for healthcare and medical readiness is a really somewhat fancy way of saying that you need to create a very strong and sustainable healthcare coalition that has strong relationships with each other, is able to do what we call a hazard vulnerability analysis and determine what the hazards are that are unique to that small region. Every region's got very different hazards. Obviously, Florida is going to have something very different to plan for than North Dakota. And we want to make sure that the coalition is focusing, since obviously resources for preparedness are very limited, that they're focusing on truly what those hazards, most likely hazards are, and what the primary gaps are that they have, so that they're addressing their gaps through planning, training, exercises, and enhancing resources and managing those resources when necessary. The second capability is healthcare and medical response coordination. And this is really recognizing that healthcare coalitions, even though they are not formal entities like a government entity may be, that they do have a role in what we call the ESF8 process, the Emergency Support Function process, which is the government's way of managing health and medical emergencies at both the federal, state, and local level. Typically, prior to healthcare coalitions, what you might see is a health and medical desk at an Office of Emergency Management's Emergency Operations Center. So the county or the local Emergency Operations Center will have a health and medical desk staffed by one or two people. And during an emergency like the derecho that I just talked about, you would then have every healthcare organization, 219 dialysis facilities, 120 nursing homes, numerous outpatient centers, obviously the hospitals, all calling those one or two people at that ESF8 desk to report their status and report their needs, what they need from the Office of Emergency Management. That gets incredibly cumbersome for that ESF8 desk. Even if you were to staff it with many more people, it still gets very cumbersome. And the other challenge is that while the Office of Emergency Management, both at the state and local levels, is phenomenal at providing resources, the resources that they are charged with providing are not necessarily healthcare resources. They are things like food and fuel for generators, which can obviously be helpful in healthcare, bottled water, really basic necessities. When you're talking about healthcare, the needs for healthcare resources go far beyond those types of resources. I'll give you an example here. We had an area in Michigan that lost telemetry in their hospitals and weren't able to do central cardiac monitoring. They certainly could have called the Office of Emergency Management and reported that, but I can guarantee you there is no Office of Emergency Management probably anywhere in the United States that has a stockpile of cardiac monitors ready to deploy to a hospital. the only way that hospital was going to be able to keep those patients there and not evacuate them was by working with EMS to get transport monitors, either off the ambulances or from their stockpiles into that hospital, and by working with the healthcare facilities to get any available portable monitors into that hospital to keep those patients there. Obviously, our goal is to not have to move patients unless it's an absolute necessity. So that's, again, why healthcare coalitions can now coordinate with each other through information sharing platforms, whether those are web-based or radios or multiple redundancies to take into account that some may go down during an emergency, to be able to share with each other the resource needs and the requirements that each of these facilities have and their general operating status. Because even if you can't fulfill those needs, just having visibility and awareness that a healthcare facility in your general area is having some trouble is very helpful to have, knowing that everything somewhat trickles downhill, and that will probably be your facility fairly soon. So getting a little bit of a heads up on planning is always incredibly helpful. The third capability is continuity of healthcare service delivery. And this is, again, where I had mentioned with the tornado and the infectious disease outbreak, we want to keep healthcare services running. Once healthcare services stop running, we are in a really, really bad place because all emergencies in this country, or in all emergencies anywhere, have a health impact. And so if we don't have healthcare services running and we have to take those out and move people over to the town next door to get them, that is a huge impact because many healthcare services are required in a very timely manner, especially during emergencies. So this capability is giving guidance to individual healthcare facilities and coalitions about how to provide uninterrupted and ideally optimal medical care to all populations, even if facilities are damaged or the infrastructure itself is disabled. And this is about keeping healthcare workers well-trained and well-educated and safe to make sure that they're able to continue to provide care during an emergency as well, because we all know that the personnel resource of healthcare facilities is really what keeps those facilities running. And then the last piece is medical surge. And medical surge has two components, one that we call a capability side and the other a capacity side. The capacity side is a little bit easier to understand, so I'll go through that first. And capacity is truly just that, adding capacity, increasing your numbers. So if we have a train derailment in an area, knowing that if you're going to get another 200 patients in a small rural area, that you have a way to increase your capacity inside of your facilities, either through strong coordination, or in some cases that's not possible, and you turn non-traditional inpatient care areas into inpatient care areas, whether those are more outpatient care areas or PACUs or other parts of the facility into a inpatient care area. So the capacity side is just that. The capability side is a little bit more difficult, and I'll use Ebola here as an example again. Ebola was not a capacity issue here in this country. We did have plenty of beds, obviously, for the patients, but the healthcare system in this country was still incredibly overwhelmed because the emergency was so different that it really taxed our capability to handle it. So that's where we've now, in this new set of capabilities, added some new things related to capacity. So special populations, particularly pediatrics, burns, CBRNE, chemical, biological, radiological, nuclear, and explosive types of terrorism that might cause a surge on the healthcare system. Those, again, are both a capacity as well as a capability issue, since we don't see those kinds of injuries, and in some cases, with regard to pediatrics, we don't always see pediatrics at adult healthcare facilities, but yet during a real emergency, there will be a need to make sure we can support that. So talking a little bit about the program again and how we've changed, I mentioned how in the first 10 years of the program, it was mainly about equipment purchasing. And then we had what I'll call kind of the middle period of HPP, which is 2012 to 2016. And we moved the shift to both capabilities and healthcare coalitions in 2012 through what we called a 5-year project period of our grant. And we gave guidance at the beginning of that 5-year project period with the idea that it would be helpful for our awardees to have a longer-term guidance of what was being expected of them for 5 full years. So we did that, and some of the things that we did were, following the slide now, the capabilities were really focused on aligning HPP with what we call our sister program, which is CDC's Public Health Emergency Preparedness Program, to integrate medical and public health system preparedness. The CDC program focuses on preparing health departments at the local and state level, whereas we focus on preparing healthcare facilities and then the healthcare delivery system in the United States. What we had heard prior to this was that because the programs were not really aligned very well, the public health departments were preparing for one thing and the healthcare facilities were preparing for another, and often at odds with each other. So we knew we had to put out guidance that had both of those different systems somewhat marching in the same direction. And I think we fairly succeeded at that during that 2012 to 2016 period. We also put out performance measures, as with any grant program, and we set a high bar for the awardees, but the program measures that we set were what we consider to be very subjective, self-reported, Likert scale measures that were not really easy to be validated and hence didn't tell us very much about what this program was doing in terms of really building preparedness. The third was that we established regional healthcare coalitions around the country, and they did certainly foster collaboration among competitive healthcare entities. And really what we looked at from that 2012 to 2016 period was we brought the people to the table. We got them there, and we got them exchanging business cards well in advance. Now we need to take them to the next step where they're actually responding together, and they're truly gelled as groups, and they are now communicating with each other both before and during emergencies. And then the last piece was we really had an effort on kind of focusing awardee burden to make sure the awardees weren't considering this just to be a grant program and checking the boxes of a grant program, but we're really focusing on the preparedness aspect of it, using the grant funds, obviously, for that purpose. So we changed things a little bit in the what we call current project period, which began this past July. And we did refine our capabilities, which were on the prior two screens that we just walked through, really to distinguish the difference between medical and public health activities, so keeping them aligned very much together. But the prior feedback we'd gotten was that, for the most part, the healthcare and the public health capabilities seem to be kind of the same. And we wanted to really be able to distinguish what the medical and healthcare delivery system's role is in preparedness. We improved our performance measures by requiring all healthcare coalitions in the country to do the same, what we call exercise in a box. It's a low-notice event. It's on our website, a no-notice exercise where the evaluation criteria and the evaluation forms are in the box, essentially. And that exercise doesn't cost any money for the coalition to develop. They can just decide to open it up and within a few hours begin doing the exercise. And we've based our performance measures now on that exercise so that we can really compare apples to apples across the country and have some much more objective data that's numeric-based or numeric value, not just Likert scale measures. In terms of healthcare coalitions, like I said, we really want to operationalize these coalitions and get them now responding together during emergencies, not just getting to know each other. And what we found with that was a lot of our coalitions were very different across the country, which is good and very important because you have to make sure that the coalitions can meet the local flavor of the town or the region that they're in. But at the same time, some of our coalitions didn't have two hospitals in it. Some of them didn't have local public health departments or emergency management agencies, and some of them didn't have emergency medical services in it. And in our mind, if you only have one hospital, you can't be a coalition because there's no other healthcare facility to rely on during an emergency. Whether that's just needing some of their resources, needing some of their personnel to come and help you out, or whether that's evacuating and moving your patients to them. You also need to have emergency management to provide you those basic resources such as fuel and other things. You need to have public health because, well, let's face it, public health convenes in a great way a lot of the healthcare system partners. And then in the last piece, you need to have emergency medical services because no matter what, emergencies require movement of both logistics and personnel and patients, which obviously EMS is ideal for. And last but not least, we made a huge effort this project period to make sure that the funding was, even though our awardees are at the state public health department level, that the funding was trickling down to where it was intended, which is the healthcare delivery system, and not getting stuck in initiatives just at the public health department, which is honestly what the STEP program, the CDC Public Health Emergency Preparedness Program, is aimed to do. This is more of a graphical depiction of what a healthcare coalition is. As I mentioned, we now have these 4 core members that you'll see in the more bold writing in the graphic and with the icons, the bigger icons in the graphic. Those are hospitals, emergency medical services, emergency management, and public health. But they're not the only important members. The reason we call them core members is that every single coalition and community really has these. Not every single community has a rural health center or you know, an academic institution, or other kinds of things that you might see here, even a behavioral health center. So we wanted to make sure that we were leaving the flexibility to the coalitions to determine their right size and structure, and not making the requirements too rigid that the coalition doesn't work for rural America, whereas we know a lot of this would work for many of the more urban or suburban places. So there is some flexibility built in, but we're very, very, very convinced that you must have at least those 4 core members to really be a functional healthcare coalition. In terms of who's in these coalitions, we have about, right now, 476 healthcare coalitions throughout the country, and inside of them, there are about 30,000 members. And I want you to think of a member as an organization, not a person. So what we're showing here in this graph is what we call, for lack of a better term, our penetration rate inside of healthcare coalitions. 85% of all hospitals in the United States are part of healthcare coalitions. 82% of local health departments, 56% of local emergency management agencies, and 27% of emergency medical services are part of healthcare coalitions. And then you'll see the other members that are very important as well, but again, much lower numbers as a result of the fact that, again, not every single community does have them, so not every community will have them in their coalitions. Since we started coalitions in 2012, we've had a 92% increase in participation rate in coalitions. Now, when I say we started coalitions in 2012, that is exactly that. HCP required them beginning in 2012, but we do have some coalitions around the country that have been around a lot longer than that. Very forward-thinking areas that decided right after the 9/11 terrorist attacks that getting healthcare working together, not just in their own individual silos, was very important. So we have some very mature coalitions that have been around for decades, and truly we look to those as, in many cases, best practices. I wanted to bring to your attention ASPR TRACIE. Our TRACIE stands for the Technical Resources Assistance Center and Information Exchange. We know that preparedness is not a revenue-generating department anywhere, especially not in healthcare facilities. We spend money. We don't generate money. And therefore, it's very, very, very difficult to get the appropriate resources dedicated to preparedness. We recognize that, and we wanted to make sure that we weren't having anyone reinvent the wheel, essentially. I remember being a healthcare emergency manager for a large hospital system in New York, and being asked right after Katrina to write a hurricane evacuation plan for all of our hospitals. And, you know, this was obviously, there were internet in those days, but again, there was nothing like TRACIE. So I started with a Google search to see if any hospital had just hopefully put their hospital planned evacuation plan in there, which is obviously very different than a fire evacuation plan. The goal in a fire evacuation plan or a structural evacuation plan is to just get your patients out the front door, and then you'll decide what to do with them. But in a planned evacuation plan, you want to have a destination mapped out for those patients really before you start moving them, and really, you know, identify what the triggers are for beginning to put that plan into motion, because in some cases that can be the most difficult decision. And so there was nothing for me to go to. I couldn't find anything on Google to help me get started. So we started writing this from complete scratch. And ever since then, I was thinking to myself, wouldn't it be wonderful if all of us emergency managers throughout healthcare, you know, who all have these big binders sitting on our desks and have all these electronic files on our desktop, could just put this all somewhere so that everybody else can access this and really figure out how to begin using it. It might not be perfect for me, and I might need to do some major adjustments to it, but just a place to start would be phenomenal. So that's really, in a nutshell, what TRACIE is. It's a place to find technical resources, and those resources include, you know, collection of both the disaster list that we get, obviously, in partnership with the National Library of Medicine. It includes expert-reviewed, subject matter expert-reviewed topic collections, where really we know that in many cases emergency managers are not academicians. They're not going to necessarily read journal articles. So we really have our SMEs go through and try to pick out from many of those journal articles and highlight kind of the main point or the key summary, and go through and really figure out which are those resources that are must-reads, that if you only have a few minutes, go with these, as opposed to, you know, if you have more time, go with some of these other ones. And like I said, using real-life tools and experiences and highlighting some of those tools and templates and other kinds of documents that would just be incredibly helpful as a starting point. So there's a tremendous amount of material that is all searchable on ASPR TRACIE. ASPR TRACIE is a free resource. But yet, if you're not the kind of person that likes to do searches on a website, we also have our Assistance Center, and they're available to provide personalized support, both by a toll-free number that's on the screen as well as on by email. And the other thing that's nice about Tracy is sometimes the answer has never really been started. You can't find anywhere the starting point for your plan or your tool that you need to develop. And that's where Tracy can then take our subject matter experts, our stable of subject matter experts, and do some personalized support to find a way to get you started, whether it's a white paper on a very specific topic that hasn't really been explored much in the literature or in the gray literature, and find a way to get you started. We did a lot of that during Ebola, where there wasn't nearly enough to go by. Very few hospitals had plans that really would have worked for Ebola. They had infectious disease plans, but more on the pandemic flu side, not on the specific requirements of a biocontainment unit. And so we did a lot of that then, and we've done a lot of that since then, and many other emergencies that have come up, because the disasters that keep occurring in this country lately never really cease to amaze me, and I'm sure many of you. And the last piece of Tracy is the IE piece, the information exchange. And this is a password-protected area for discussion among users. It's more like message boards and areas where if you're having a problem and you want to reach out to the community of users in Tracy, you can post a thread and other people can respond to your thread, and you can actually more privately share documents that way if you don't want them kind of posted on a website. Or if you just want to have a example that we've seen lately is things about staffing, how certain hospitals staff their units during disasters. And those are things that maybe from a business perspective you don't want to put up on the World Wide Web, but you might just want to float around ideas with other individuals that happen to be reading the information exchange and maybe willing to more privately share information with you. I want to talk a little bit about the Centers for Medicare and Medicaid Services Emergency Preparedness Rule, because this is where I feel like the audience on this call might get a tremendous amount of both questions as well as areas where you can really be of assistance. The Emergency Preparedness Rule is the first time that the Center for Medicare and Medicaid Services has put out a rule about emergency preparedness. And this is a very, very broad rule that applies to 17 different provider and supplier types. So really, about 70,000 different healthcare facilities and organizations are impacted by this rule. And its goal is to really set baseline levels of preparedness. And when I say baseline, I mean baseline levels of preparedness. The CMS Rule is a wonderful, wonderful starting point, because as I said, we never had this. We've never had this in the past. We all have seen the pictures of what happened with healthcare facilities following Katrina, and we've seen healthcare facilities get more and more prepared, but we certainly are not where we need to be. There are still a lot of healthcare facilities, maybe not as much hospitals now, but other kinds of facilities, nursing homes, dialysis facilities, in more recent emergencies like Hurricane Sandy that just didn't really have a plan. They didn't have any planning for emergency preparedness of what they were going to do if they shut down and where they were going to direct their patients to make sure that there was a fairly seamless continuity of care for them. So this is a new rule that will be incorporated into the routine survey that CMS does of all of its providers and suppliers. Its goal is to establish a baseline level of preparedness. Where we think that the best kind of part of this rule is that it doesn't just say that the facility itself needs to have a preparedness plan and needs to exercise that plan, but they must integrate that into the community's planning. And so I like to think of that as a code word for be part of a healthcare coalition. Really know what the plans are for your entire region, make sure they know your plans, and exercise those plans together. Know how to get in touch with all of your the healthcare facilities in your region. Kind of don't operate as an island is really the best way to say this. And again, we're looking to do this to improve the continuity of care across the entire healthcare system, and also to increase executive level buy-in. Healthcare executives are incredibly busy. They have a lot of financial pressures on their plate. And as I mentioned before, emergency preparedness is not by any means a revenue-generating program. So we want to make sure that executives are aware at all times of the level of preparedness their facility has, as well as their region. Because in some cases, it's going to take those employees of those organizations and those healthcare facilities to work for the healthcare coalition. And in some cases, that's an in-kind contribution. That's not going to be paid for. Your time isn't going to be paid for to help write the regional plans or to go to a regional meeting. But it is in the best interest of the healthcare facility that you work for because having a more prepared region is obviously going to do wonders for your own facility. So we wanted to use this as a lever also to increase executive buy-in for preparedness. We think, again, as I mentioned, that this creates a tremendous amount of opportunity for healthcare coalitions. Healthcare coalitions in many cases are sort of, in some ways, struggling to show their value to those executives. They show their value to the emergency managers that often sit on those coalitions. But many of the C-suite folks, whether it's the medical officer, senior medical officer, or the chief nursing officer, are not aware of what these coalitions are and what they can potentially do. And this is a case where, again, we vision that the healthcare coalitions can really participate in the planning of the individual healthcare facilities that are impacted by this rule, help them write their plans, help them exercise their plans, which does two things. Number one, it helps the preparedness of that organization, but it also helps the coalition's preparedness because they're going to know what the plans are of that individual facility and they're going to have those relationships built in. It also may increase the financial sustainability of these coalitions because rather than hire a high-priced contractor to perhaps go and do this work, if the coalition does it, I bet it would be for less money and you might get a very high-quality product as a result. A lot of times we know that the coalitions themselves don't have tremendous amounts of time on their hand. As I said, the funding is limited, and then many of them don't have a tremendous amount of full-time employees able to just sit down and start crafting plans from scratch. And that's, again, where ASPR TRACIE comes in when they have a dedicated rule, CMS Rule page that has a tremendous amount of resources that can help the 17 provider and supplier types with what it is that they need to meet the requirements and the conditions of participation for the rule. Again, it's going to need to be customized and tailored, but it is at least a starting point. And last but not least, we have worked with the Center for Domestic Preparedness, which is through the Federal Emergency Management Agency, FEMA, to offer a health sector emergency preparedness course that will provide the healthcare providers and suppliers with training to achieve the 4 core emergency preparedness elements that are outlined in the rule. Most courses at the Center for Domestic Preparedness are called residence courses, where you travel to the CDP in Anniston, Alabama, and you take these courses for a week and you travel home, and the travel is all free and the government funds it. But we didn't think that would be the right thing to do for this course because healthcare executives, again, are incredibly busy and they don't have the time necessarily to travel for lengthy periods of time. So instead, we created a non-resident course where the course will travel to you. If a coalition and a group of hospitals can secure space, essentially, secure some space, and coordinate invites for other local healthcare facilities, not just hospitals, but any of the 17 provider supplier types to also attend, then FEMA is willing to send some of its trainers to come up with all of the equipment, all of the supplies, everything that's needed for the course, and host the course there. It's an 8-hour course, and it's really designed to help understand those requirements that are outlined in the rule and develop the skills and knowledge to achieve those requirements and develop plans and everything to achieve those requirements. The only, again, responsibilities for the course host are to provide a classroom or an auditorium, recruit the audience, which is the 17 different CMS provider types, and provide a point of contact from that host organization to the trainer at the FEMA site, and then they will certainly work very hard to get that course out to you. The course just started in November, and there have already been nearly 2,000 individuals trained in that course throughout the country. So it's moving at a fairly rapid pace. And with that, I'd like to turn it over for questions.
So thank you. Fabulous. And Jen, have you been monitoring questions?
Hi, yes. We do have a couple of questions in the Q&A pod. One was, how does ASPR envision sustaining over 450 HCCs with an emphasis on response?
So what we mean by response is maybe a little bit different than other response entities. We don't expect healthcare coalitions to travel lights and sirens to a scene and, really tactically hands-on response. What we do mean by response is that the coalitions are, whether it's in a virtual way or together all in one conference room or one operations center, that they're all getting on and they're sharing information with each other during an emergency, and they're participating in strategic planning during that emergency. So what we mean by that is many of us probably consider this year's flu season to be an emergency. The levels of patients were just as high, if not higher, than 2009 H1N1, and in some cases the acuity was as well. So it was a really tough flu season, and we had coalitions that came together early on in the fall and said, when we see certain things happen, here are our triggers. When we see certain things happen, we are going to implement standard policies across the entire coalition on visitation. So in other words, no children under age 16 can go into the hospital once we see these identified triggers. And we will all put that in place on the same day, because the last thing you want are patients picking which hospital they're going to go to based on inconsistent policies across the board during emergencies. Those are what we mean by response. We're not talking about coordination of necessarily vetting of resources. It's important to know from a situational awareness perspective who has what resources available, but the coordination of those resources and the movement of them around and the tracking of them is not always going to be a coalition responsibility. In some cases, coalitions are very mature and are doing that, but in other cases, that's still a local government responsibility to get that piece done.
Okay, thanks. Another question we have is, could I find a CEMP for an FQHC?
So to decode that, yes, if you go on ASPR TRACIE, I can't speak definitively because I'm not on the site right now, but I believe for each of the provider types, we do have at least some examples of tools and templates out there. And if you're really looking for a specific one for a specific kind of facility, such as a federally qualified health center, and you don't see one there, we can certainly reach out to our partners at HRSA and try to get one of those for you and then post it on ASPR TRACIE so that everybody can see it. So please visit the ASPR TRACIE website to see if what you need is there, and if not, I'm sure that's something we can help find for you.
And I just put the link to the CMS rule from the ASPR TRACIE page into the chat box. So I know that some people are on the Q&A box and some people are in the chat box. So that's where it is.
Thank you.
Okay, another question we have is, do you have any insight or comment on the transfer of the SMS program to ASPR?
So for those who are not familiar with that transfer means basically that the SMS, the Strategic National Stockpile Program that is part of CDC, will be moving under ASPR. And really, this makes perfect sense in the idea that the purpose of the Office of the Assistant Secretary for Preparedness and Response is to coordinate the federal government and the Emergency Support Function 8 during a healthcare emergency. We have an entire logistics division here within ASPR, and we have, in addition to that, health personnel through both the Public Health Service as well as the National Disaster Medical System that we often deploy during emergencies and did many deployments during the recent hurricanes. So from a logistical standpoint, it made more sense to kind of put all of the emergency logistics during a healthcare emergency under one organization, which is obviously led by Dr. Robert Kadlick, who again really serves as the federal government's incident commander during a public health emergency.
Okay, thanks. Another question we have is, I'm in an RHC and a department for the hospital. The clinic is off campus from the hospital. Do I still need to have my own preparedness plan, or can I use the hospital?
Again, I am not CMS, so I don't want to guide you the wrong way on this, but certainly we can put you in touch. There is the survey and certification group at CMS can probably answer your question on that. I would just hate to guide you in the wrong way. And if you need any connections to that, you can feel free to reach out through the NLM group, and they can put you in touch with us, and we can put you in touch with CMS. But yeah, I think it's best if you work with CMS on that one.
Okay, thanks. Are there resources available for local emergency management agencies to better understand their roles and responsibilities with the new CMS guidelines?
As far as specific resources and roles and responsibilities, again, I would just say with that Offices of Emergency Management are not usually, and I don't think any are really covered providers underneath the CMS rule. They don't receive Medicare, Medicaid funding, so they don't have any conditions of participation officially through the rule. But that said, the Office of Emergency Management, and as an integral partner in healthcare coalitions, have planning experts and know their communities incredibly well, and they know how to bring together various different organizations within their communities. So to say that they don't have a formal role, meaning that they don't have a required role, is correct, but yet I do believe they have a responsibility to assist the healthcare facilities both through the coalition and in working with their local public health department to make sure that all of the providers that are covered under this rule know where to begin, know how to get started, and are kind of being, in some cases, coached on emergency preparedness. Because what we have heard from many different healthcare facilities is, small dialysis centers, certainly not the large chains, but small ones, they have an administrator who maybe this is going to be 5% of her responsibility or his or her responsibility to do, and she doesn't even know where to get started. One of them put it to us in a funny way. She said, I don't even know how to spell emergency preparedness, let alone begin writing a plan. And so that's where those of us that have been in planning for practically our whole lives, we can really lend a hand and really, really help out. And it's going to pay dividends for the Office of Emergency Management in local communities when there is an actual emergency, if those plans are both good plans, quality written plans, well-trained on the plan, those facilities are well-trained on the plan, and then they're well-exercised because they're going to have less of a crisis on their hands to deal with when there is an actual emergency.
Okay, thanks. That's all the questions I can see right now. If anyone else has any more questions or clarifications, please go ahead and put them in the chat pod.
So, Jen, maybe you already asked this. I've also been looking online for some answers. There was a question, do you have a link for how to register for the healthcare sector emergency preparedness course? I have a flyer for a local one, but couldn't figure out how to register.
Yes, so I can actually send to you, it's actually an email of an individual at the CDP. I can actually send to you his email address, and you can push that out to all the listeners on today's call.
Okay, you probably already got that. This is great. I'm really excited about this. So I had a question. You showed, well, I put up the URL for the ASPR TRACIE website, and you were talking about the information exchange and how we can go on there and ask questions password protected. So I assume that just not just anybody can get into ASPR TRACIE in that way. So what's the process for that, and who do you let in?
Yeah, so really the whole purpose for the password piece is to make sure that, number one, lots of spam isn't going to come into the information exchange, and to make sure that people sort of are who they say they are when they really a verification process of your email when you register. But we are not picky. We don't say, oh, because you have a .com rather than a .gov or a .edu, we can't let you in. If you are really truly involved in healthcare preparedness or public health preparedness or on the preparedness side, there will be no problem getting into it.
Okay, great. So they just go to ASPR TRACIE and fill out the form and...
Exactly.
Okay.
Yeah.
All right.
We do have one more question that's just come in. How many drills and what type are required for the CMS rule? My understanding was 1 EMP activation and 1 community-wide type drill.
Yeah, so the important part about the community-wide type drill is that it does not necessarily need to be completely separate. You need to demonstrate your, if you do an emergency preparedness drill in your own facility, and there are other facilities exercising at the same time, and then you engage other facilities in that more of a regional drill, that's sufficient. We have a lot of folks thinking they have to do one individual facility drill and then later on a community drill. But the best way to leverage your precious time here, is to be sure that when your community drill is taking place, you also exercise your own individual plan at the same time and take that kind of exercise into your facility, if that makes sense.
Okay, and the same person just asked for a little bit of a clarification. Do you mean several of all my sites at the same time?
So when you say all my sites, that to me, and again, maybe I'm reading this wrong, but it sounds like all of one corporate health system site. That's not necessarily a community-wide drill. Community-wide drill needs to make sure that it incorporates the emergency response system. So that is obviously local government and other kinds of agencies as well, not just you know, if you have 5 clinic sites all owned and operated by the same entity, that you're exercising all of those at the same time. They have to engage your community partners.
Okay, that's all I have. Thank you.
Great.
Okay, well, Melissa, do you have some final words you want to offer, or?
Yeah, I just want to thank you all so much for your time. I know it's tough to devote an hour to anything, but I think this is a wonderful opportunity. When Tracy asked me if I would do this, I thought, you know, this is such a unique group to be able to speak with, and you're all in such a position to really be able to help the audience that we're trying to message to that often is really difficult for us to get out to everybody. So I really do want to thank you. And again, I would just appreciate keeping the lines of communication open, either through directly through the NLM or through the HPP mailbox, which is hpp@hhs.gov. I do see one other question in there about whether or not the Health Sector Emergency Preparedness course incorporates HICS or the adoption of the Nursing Home Incident Command System. And it does have, the course does have a large incident command component to it, although that's not the only component of the course.
Okay, and yes, I second all of these excellent, informative presentation, and I just want to remind people on this call who might be at the PrEP Summit that both ASPR and NLM will have a booth at the PrEP Summit. I think we're right across from each other, so you can run back and forth to each of our booths and pick up information. We will have 2 presentations. The National Library of Medicine, we'll be offering our disaster information specialization. You can get that while you are at the conference. So that's exciting for us to be able to offer the courses to allow you to receive that certification while you're there. And we'll also be talking about our disaster research response initiative with the National Institutes of Environmental Health. We'll also be in 2 weeks at the Public Library Association meeting with a booth as well. So that's places you can find Tracy, ASPR, and NLM. So, thank you so much, everybody, for staying on for the hour, and stay warm. Don't shovel too much at one time, and we'll see you again. Thank you.